Super. Okay, I think we're all set here. Well, welcome everyone. We have a few housekeeping items to go through. Let me advance the slide. But please first introduce yourself in the chat. We'd love to know who's here. And we will also use the chat box throughout the presentation. So please comment or ask questions. You can also flag any technical issues that you're having and we'll help resolve them. Our conversation is being recorded today and will be archived on the GSA website. You'll find recordings of the previous 3 conversations there as well. Let's see, there's another note. Yes, we'll ask you to keep your video off and audio on mute until it's time for discussions. So how did we get to this point today of hosting COVID conversations? In March of 2020, GSA pulled together a COVID-19 task force when we realized that the pandemic was disproportionately impacting older adults. And this task force represented multidisciplinary experts in a variety of fields, tasked to stay apprised of the pandemic and reflect upon, identify, prioritize, and recommend steps, tools, resources that only GSA is uniquely and well qualified to develop to support its members and in turn older adults. So one of the pieces that the task force worked on was a research agenda. And so you'll see here the 12 areas that they prioritized after speaking with GSA interest group leaders and other leadership throughout the organization. These 12 areas had many elements within them to give definition to what they mean and components that need more research attention given so that we can all better understand how the pandemic is impacting older adults. You can see, yes, the full citation at the bottom and link to the article. The GSA Journals are publishing quite a bit on the pandemic, and here are some of the earliest content published on what was happening with COVID-19. There are a number, as you can see, of special collections, virtual-only collections, and individual articles detailing a variety of aspects of what's happening with older adults. So you can also see the links here and read the articles as you like. From all of these articles, yes, we've now pulled together this COVID conversation series, convening authors who are experts in a couple of different topic areas to share their research, to discuss what we know, what we don't know, and what we're still learning and apply that in the future. You can access the recordings again for all of these conversations at the link at the bottom of the screen. So with that, welcome to our panel today, and we're so glad to have all of you. I'll turn things over to Dr. Albert to get our conversation started. Dr. Albert?
Thank you, Judy. And I even remember to unmute myself. I'm speaking from my outdoor office in Pittsburgh. That's not a fake background behind me. It's really terrific to have the 4th of our GSA COVID conversations. Let me thank GSA staff again for pulling it together so wonderfully. And we have covered so much ground in this series. You saw the slides that we presented a second ago. And today we want to take it a little further. I have some terrific guests with us today. Karen Fingerman is a professor in human development and family sciences in the School of Human Ecology at the University of Texas at Austin, the College of Natural Sciences. And north of Texas, in North Dakota, we have Heather Fuller, who's an associate professor in human development and family science. And I'm a professor at the University of Pittsburgh in our Graduate School of Public Health. And I've had the pleasure of running this series. And this is, as I mentioned, the 4th of our topics. So the conversation today is, how well did we adapt? And there's a lot in there, and even defining that topic was not so easy. But some of the topics we want to get to today are, was the caregiver workforce equipped to respond to the pandemic? Did families, how much trouble did they have navigating these changes? And what about older people themselves? What was some of the responses to the injunctions to distance or isolate? And maybe even further, the fear and anxiety that emerged in the early days of the pandemic. And to be quite frank with you, when I discussed this topic with my colleagues at GSA, I thought we might have missed the boat entirely. The pandemic would be finished by the time the GSA meeting rolled around and we were in the midst of our COVID conversation series, but they were wiser than I was and recognized that no, we would be living with this for some time, and it would still require the expertise of gerontology to respond. And I think that's where we are. Rather than belabor the points further, let's hear from our two speakers for a sec, just to give a short background about their research and how they came to think about COVID and aging. Dr. Fingerman, could you please speak for a bit?
Yeah, they asked me to tell you a little about my background and my career. I should say I came to this topic at the time that successful aging was sort of just being discovered. While I was in graduate school is when Jack Rowe published the book, Successful Aging, and I was very excited about the positive aspects of aging. And so I study social and emotional aging, which tend to improve with age. And it's exciting, it's great to watch, and you keep getting to be optimistic that there's even better ahead of you. I've been particularly attentive to, social relationships. I have a couple of studies I've run. One is the Family Exchanges study, which has looked at how intergenerational ties have qualities, support systems, and so on between young adults, midlife parents, and aging parents. And that became more relevant, I think, during the pandemic in a lot of different ways. And some of the evidence of that is that as soon as vaccines came out, if you followed the news, one of the first things people did is to reunite with their aging parents. It was, very anecdotal, but it seems that was sort of that heightened, if you will, recognition of the importance of this tie once it was impeded. I also have directed the Daily Experiences and Wellbeing study, in which we tracked 300 older adults throughout the day with various devices. We looked at we had on Acticals, which are like super good Fitbits. I'm not wearing one, I'm wearing a Fitbit, but like if I had a really good one, because if you look at your Fitbit website, it'll say, you move it around on your wrist, it's going to give you a different indicator. The Actical is very precise. We had them complete what are called ecological momentary assessments. So they did some brief surveys 7 times a day. And we had low-income seniors. I could tell you a whole story about using these devices with a variety of seniors, but I will tell you, just briefly digress, take them offline because updates are not your friends. We also got sound files. We have 100,000 sound files we captured, so they went about their day, and photographs of their rooms and so on. What we did is during COVID, when this hit, we got a small amount of money from our university and we followed them up. And we looked at whether they live alone, whether they live with other people, a variety of indicators of how they were doing during COVID. So that was sort of my main COVID, initiative. I did it in April, starting in April of 2020, May and June, when the shutdowns had just begun. And like, Stephen said, I was thinking, I can remember when it hit China and I was like 3 weeks, they were 3 weeks without, well, here we are, 16 months later. Anyways, I did it right at the start, and I'll talk a little bit about that. The other thing that happened right at the start, even right before it happened, a colleague of mine whose whole family is in China, and she's originally from China, saw what was going on there. And we wrote an op-ed piece, really just as it was getting started. I mean, it was in March, about the technical issues that would come up. And then I wrote a USA Today piece with a colleague on the Committee on Aging of APA, just looking at the variety and heterogeneity of the aging population that was being obscured at that time. And I think we're going to talk about that more, but there has been a justifiable focus on individuals in long-term care, on individuals with weakened immune systems and such, but it does skew an understanding of the older population. And we wrote that in the spring also of 2020. And then there was a variety of other media things. And I guess I point that out to you because I think we are, as sometimes people are shy about using their expertise to look at different problems. So my colleague who saw the technology issue is one of my collaborators, but she's the expert on technology use in late life. I know something about it. I've written some papers on that in how social relationships are mediated, but she had more expertise, but I have enough that I could think about the messages that people might want to hear. And I think I should add, I direct the Texas Aging and Longevity Center. And I'm also the director of research for the Center on Aging and Population Sciences here at UT. And what that does is it gives me the opportunity to learn more about the field. I also teach a course, both at the graduate and then the undergraduate level, a big survey course that goes from cells to Social Security. And so I do feel like, I keep up to date to some extent. I keep a little bit of a tab on many, many different areas of aging. And I feel like, first of all, it keeps me interested in everything and it lets me know a lot of people in the field, but it also makes me feel a little more confident when something like this hits, that I have at least an ability to tap other experts and bring a voice to the field. And so I think that might wrap up. Maybe I'll think of some more things to say, but I think that kind of gives the overall overview of what I've been up to and what I'm thinking about COVID.
Okay, thank you, Dr. Fingerman. You raise a good point, which maybe we can return to, that so many of us had to become advocates and speak to the public about the pandemic and aging, and how prepared were we? And maybe that's a topic for a future day. Let me turn it over now to Dr. Fuller from North Dakota. Give us a little bit of your background.
Yeah, great. Thank you so much for inviting me to participate in this webinar. I'm really excited just to get to have a conversation about what we've been learning about COVID over, shockingly, as Karen said, over the past year and a half. I was kind of in the same realm. We thought that this would last a month or two when we'd be done by summer 2020, and here we are. So my background is in developmental psychology. My PhD is from the University of Michigan. And from there, I came to North Dakota State University in the Human Development and Family Science Department. And I focus on aging and lifespan development, but more on the aging side of things, and look at social connections and relationships and how that impacts well-being, particularly for those that are the older of our older adults. So I really enjoy trying to study folks in their 80s and 90s when possible, and understanding their social connections. I lead a couple studies here in the North Dakota region. So I do a lot of regional work, which has really brought me to focus a lot on rural aging. So prior to moving to North Dakota, I was very interested in cultural context and conducted some research in Mexico and research in Ecuador. And so I was really familiar with those cultural contexts. And once I moved to North Dakota, I really came with a realization that rural is its own cultural context. And so I've spent the past 10 years learning a lot about that cultural context and what it means for aging, and finding that aging within small towns and rural communities is very different than what it looks like in metropolitan areas or large urban areas. So that's been a major focus of my research in the past few years. Another aspect is that I have a strong program of research that is community engaged research. So I'm at a land grant institution. So a key part of our mission is outreach within the state. So I do a lot of program evaluation research, trying to help organizations understand how they can best meet the socio-emotional needs of older adults. And so we're doing a lot of great work in how to help people age in place, how to promote social engagement and connections, which are critical to aging in place. You know, we think about aging in place a lot being about, do you have the resources? Can you get to your medical care, which clearly those are important things. You have safe housing, all of those are very important, but we're learning that social engagement is really, really critical as well, as we have such a big focus on social isolation and what that means for people's well-being and even longevity. So that has been a really important part of my research over the past few years. And I can really speak to how much programs that are serving older adults have been just really thrown an incredible loop by COVID, how it's changed how they have to run their programs, how they have to try to serve older adults despite the inability to go to people's homes in person and provide those services in person, and a lot of the obstacles that come up when you need to try to adapt to technology, as Karen was speaking to, but you can't train them to use that technology in person. So it doesn't work very well to, in the midst of COVID, try to mail somebody an iPad that is in their 90s and a router or whatever the device is that gets them connected to the internet, and hope that they'll be able to figure that out on their own for the first time ever. So we've been learning a lot about that. If I can digress a little bit, so the strong interest that I've had for the past year and a half in COVID, similar to what Karen mentioned, you know, right away when this was becoming a really important thing in our region back in March, a colleague and I got together and we said, you know, we should try to understand this. You know, this looks like a once in a lifetime situation. Me being interested in social engagement, I really thought this is really almost a natural experiment. We're asking people to socially disengage for who knows how long. And let's try to understand that. So we decided to start a mixed methods interview study. And we recruited older adults we kept it to our region. So really, I'm in Fargo, North Dakota, which is right on the border with Minnesota. So really the Minnesota, North Dakota region. And just recruited through newspapers, through some organizations. AARP was a great help, but just tried to see how many older adults can we get that would want to just do a phone interview for us and just tell us about their lives and how they're coping and how they're adjusting to the social distancing. And so we started that in March, right at the end of March, and continued into April. And we were surprised how many people we got. We ended up interviewing 76 older adults and then following them through the year. So we didn't necessarily expect to keep interviewing them, but as the pandemic went on, we interviewed them again in June. So kind of 3 months after the pandemic had started, and then we kept going. 6 months, we talked to them again in October of 2020. And then the last time, who knows, but the last time we talked to them was April of 2021. So a full year after people had been in this lockdown. I say lockdown in quotes because our region never actually locked down officially, like some other parts of the country, which is something we can speak to how different geographic differences really probably affected how older adults coped with COVID. But I can do that study. Yeah, go ahead.
Oh, Heather, I was just going to say, one of the things that is really, I think, impressive about how gerontology has worked is how quickly we responded. Like your point, I know Neil Charnas's group had, because they do technology and aging, they had instructions up that they had tested with MCI for how to use Zoom, but they did it like the first month. And I know for us, the Texas Aging and Longevity Center, we had stuff up immediately. And I'm telling you, as academics, it's usually like, well, it's not in my semester plan, and maybe next semester. I mean, it was really a different pace, and it was impressive, like how many resources were out there, because we weren't generating all of our own. We were connecting to Neil's group, and we were, it was just crazy. And like you said, there have been so many studies that hit the ground. And again, like I'm planning a study a year and a half from now. I never just tomorrow put a study in the field. And I think that was something I didn't know we could all do, but apparently we can. So
and I mean, I think we had a lot of help with that too. I would just like on my end, I remember when we first, launched this study, somebody that had seen it in the newspaper that was a colleague of mine said, how did you get through IRB that quickly? Well, my IRB saw it and really, put it at the top of the list. They said, this is very timely and urgent. Let's get this processed as fast as possible. So
you're right. There was just an astonishing array of support that should be definitely recognized. I know for our center, one of the things you might not think about is that animal care must occur constantly. And there were people who, there was someone who self-isolated on campus. And then digression, but we had this huge freeze last February and we are not built for anything. And it cut off our electricity, our water, our food supplies couldn't get here because the roads were iced over. And this became very problematic for older adults, but it also became problematic for a lot of facilities that we use as researchers on aging. And there were people who moved to campus who just are not faculty. There are support staff who moved there during this thing because they had a generator there and they were keeping water there, and they got the water and the heat to a variety of things, our instruments, our animals. Anyways, so yeah, you're absolutely right. I don't want to just say it was us. It was an entire world that mobilized for us to keep learning about COVID.
Mm-hmm.
Well, thank you both for the background. And clearly there's a whole other topic on how academic gerontologic research reacted and changed with respect to the pandemic. And maybe we will be more nimble and flexible as a result of this whole thing. Wouldn't that be nice? We will see. But let's turn to the matter at hand. The other COVID conversations have been kind of somber. They were about mortality and predictors of which nursing homes had worse outcomes, and also which subgroups of older people suffered the most in the early phase of the pandemic, and how ageism seemed to thrive during the pandemic. And we had a wonderful discussion just a month ago with some colleagues from Canada and Israel on this regard. Today, maybe we can pivot a little bit to some of the positive things, but don't let me force you to speak this way. But I think we can talk about resilience and coping, which have really fallen out of our COVID conversations till now. So let me start. I really love the introduction, Karen, that you and Carl Pillemer did, I think, for the Journal of Gerontology, Psychological Sciences, to the special issue on COVID. I think I have that right. Carl Pillemer.
Yeah, Carl and I wrote that. Yeah.
And you raised so many good questions, and it's a years-long research agenda just to respond to those questions. But let me throw them back at you if you don't mind, or at least some of them. One of them is a claim that older adults overall may be coping better with the effects of the pandemic than younger people. So let me ask you, what's the evidence for these superior coping skills? And is it a surprise, or is it consistent with what we know about human development?
Well, there were, as we just talked about, people hit the ground running with studies. And so several national studies actually looked at young adults to older adults. And I was on one with Kara Burdett where we managed to get into the American Consumer Survey. They do a major national study every month. And they agreed to put some questions in so we could look at a national study of people and how they were dealing with stress. And the older adults reported less stress than the younger adults. The same thing, Laura Carstensen did a study, exact same like sampling frame, exact same finding. We did some questions in our COVID daily study, and we found that throughout the day, the two emotions that older adults in our study reported the most were gratitude and being content. And then they were reporting less. They reported it, but they didn't report nearly as much loneliness or stress or anxiety. And I think it's pretty consistent with what we see in the literature on the whole. Now, again, we can go into the exceptions of people who have health problems, people who are isolated, but that's not the majority of the adult population. So when you just take an adult population, you're going to get the effect of better coping. And there are a variety of reasons for that. There's what's called the positivity effect, where older adults tend to gravitate more towards positive information, and you can test that a variety of ways. Have them read stories, have young adults read stories. The older adults will remember the positive more. Younger adults attend to negative for a variety of reasons, probably very adaptive in a world where, you need to be wary. But the other things that we see is both experience and perhaps social structural. So these young adults had their lives disrupted in a way that could be extremely disruptive in the long term. We had people who had to stop college so that could support their parents who had just lost both their jobs. The older adults also were more accustomed, if they were retired, they may have had routines that didn't need the structure that work and such. They weren't trying to work from home remotely. They weren't trying to deal with small children getting on Zoom. And they also had familiarity with the idea that being at home and generating their own activity if they were in that sort of retirement. But that kind of combination set things up for them, set up that if we had predicted, I think we would have predicted that on the whole.
Great. So the positivity bias of aging might have been an asset in the pandemic. Is that what you're saying?
Yeah, and also I think the experience. So there was a study a long time ago after the Loma Prieta earthquake, which was like in the 80s or early 90s in San Francisco. And what happened is that the older adults did much better. And it was partly that they'd lived through so much. And they said, well, we've had really big earthquakes that destroyed a house of mine before. And it was inconvenient for quite a while, but then, we lived somewhere better. So they had all this experience with things that are very distressful and that they'd already coped with. And that's on the whole. There are, I don't want to minimize the trauma that many older adults suffered, but on the whole, those things contribute to a better adaptation.
Okay. Heather, do you want to jump in? Is this consistent with your findings in your research?
Yeah, this just rings a bell so much. So I wasn't comparing age groups in our study, but a couple of things that we definitely saw was this positivity bias, just kind of this overwhelming positivity. We'll get through this, things will get better, and just a focus on the positive that was just really refreshing. I think we went into this study thinking about the physical threat that COVID had for older adults and expecting there just to be a big risk, right? Older adults to really be stressed out by COVID. And when we asked them about their stress levels were low, and we would probe that and say, is there anything that you're worried about? What worries you? And they would say, I'm worried about younger people. I'm worried about my kids and my grandkids and, these people that are trying to balance raising, homeschooling their kids and working from home. And so they really saw what younger people were facing, and it almost put it into perspective for many of the people we were interviewing. They say, I'm fine. Like, I don't have those same stressors that I see all the younger people having. I'm concerned about the younger people. So we also saw a lot of that life experience come into play, where people would reference times in their life, whether historical events or personal events that they had experienced, and just, been like, I've been through things like this before. So having lived 80 years, they lived through similar things, or many of our participants, they recalled polio when they were children, and they recalled some of the precautions and restrictions that they had in their families, that they weren't supposed to go different places, or they had times where they were essentially quarantining because there wasn't a vaccine available yet, and there was a polio outbreak. So people really used their life experience. We saw that too.
Let me push you both on this question. I could imagine the positivity bias may be leading older people to underestimate the gravity of the pandemic, and perhaps not to follow the distancing guidelines or the isolation guidelines. I've seen this close up with a few older people I know, where it made even some conflict within families, where the adult children were not so happy with mom taking the bus because mom needed to see something a little different in the neighborhood that day. Could the positivity bias actually be negative in that way?
No, absolutely. That was, I wish, I wish I'd studied that as well. At least at the start of the pandemic, the midlife adults wanted to really protect their parents. And that was definitely what you're describing. I don't know that I would have predicted that, but it does make some sense in terms of things. I don't think I would have predicted that, but it makes sense post hoc to think, well, if you're socio-emotional selectivity theory, for example, you want to get the positive events and the positive feelings, then you're going to crave that and seek it. And there is an issue where I think that there was sort of a sense that I don't think we've studied very well, the sense that I don't have that much time left.
Mhm.
And I'm not going to spend it protecting myself.
Right.
And so I think you're absolutely right. I think that occurred. I think that not the opposite, but I think the source of tension right now is clearly political divides and concerns over the vaccine. And I'm not sure that that's age associated or generation associated, but I think at the beginning of the pandemic, it's exactly what you described.
Right. Heather, any thoughts?
I would say to an extent, yes, I think it's possible, but just based on the interviews that we did, even despite politics, right, which we heard a lot about politics, we did not ask about politics, but we got to hear a heck of a lot about it. We still saw people following the precautions, right? So they would say, this is dumb, but I'm wearing my mask, or I don't agree with this, but I'm staying home. And for older adults, in our sample, the average age was 82. They were all over 70. So we were looking at, kind of the tail end of the baby boomers, but then silent generation. So we were looking at a generation that just seemed to be more, not necessarily compliant, but just more focused on the general good, right? And that was a part of where they talked about their life experience too. They had been through times in their life, or they had heard from their parents about, World War I, World War II times, the Great Depression, where we really all just we had to chip in together. We had to look at the greater good. And even if you didn't agree with it, you still, did your part. And so we heard a lot of that, even from people that didn't really think that the pandemic was as much as it was. They thought it was blown up, that they didn't necessarily need all those precautions. That they were still following the rules, very different than what anecdotally I just saw amongst younger people. And I think that is probably reflective of what we see in the vaccine rates, that, older people are getting their vaccines at such a higher rate than young people.
Right.
It's a bit, to Stephen's point, though, in terms of the underestimation, I think, though, if we actually were able to track behavior, that what older adults might be calling precautions may not be the same thing that we as scientists are. I mean, it's anecdotal, but people will say, oh, I'm really, I only see my friends who are also careful, and they only see their family who are also careful. And there was, you know what I mean? So I think that may be an area where if we had the data, it may be something that we as gerontologists need to consider is, how do you balance not making them anxious? You don't want to enhance anxiety in older adults by saying, you're going to die if you see your friends or whatever, but you also do want to find ways. And I think that might be an area where we haven't had to grapple. And it might be an area where we need to grapple more in the future, is how to truly embody risk in a way that is beyond just, it's again, maybe that positivity effect. I'm doing everything, but you wouldn't necessarily consider what they're doing everything. So I think it's a difference between self-report and behavior and how we would intervene. And I don't have an answer to any of that.
It's a great question. I can remember at one of the geriatrics rounds here at the University of Pittsburgh, there was a discussion of an older gentleman, he was 89, who wanted to have a birthday party and invite his friends. And this was in the pre-vaccine part of the pandemic. And we, the clinicians and we hangers-on, debated, should this man be discouraged from inviting his friends to the birthday party or not? And the consensus at the end was no, that he was 89. This was a very important event for the man, and who knows what would happen in the future. And the harm from enforcing the distancing might have outweighed the benefit, but controversial, and maybe speaks to some of these issues that we're raising today. Very interesting. Yeah.
I think, Stephen, it also speaks to, I'm not sure that we have considered how important the ethicists are to gerontology. And I think we, pay some lip service, some thoughts about it with dementia and such, but really, I think that all of it came down to a lot of these ethical, moral debates that you're describing. It might be an area, again, where we could have more conversation and thought for the future.
Now, for some of the isolated population of older people who are in their homes, even, who maybe most of their contact is with a home health attendant of some sort, or some kind of support, they became very important to the lives of these older people. And one of the questions you raised, Karen, in your editorial is these supportive care workers became the only source of social contact for some of these older people. Were they prepared for it? And what can we learn in this regard?
Yeah, I think that that's an area. Now, some of them were. I mean, when the other interesting thing for me as a researcher is how connected I became to the agencies in Austin. And some of them were definitely prepared to the extent that they, Meals on Wheels is a major they do a lot of social services in Austin. And they, at some level, were prepared, but I think that they were not prepared for trying to connect without being able to connect. So they were dropping off meals that were frozen for several days because they wanted to protect their people. And so that change in model, I think it was problematic for people who'd been doing that. And I think that for a lot of agencies that did become an issue is how do you meet the social needs? And one of the things we saw in our study, which was a little discouraging, is that when we looked at the people who lived alone, what we found is that any kind of in-person contact, and remember, this is right at the start when people really were shutting down more, any in-person contact increased their mood, positive mood, diminished loneliness, all of that. Telephone calls somehow did the opposite. And of course, we all want to interview them with the phone. So if that person's getting worn out who came and just was the service provider, because they are, if everyone you encounter is needy and needs your social contact and doesn't want to let you leave and you're the source of conversation, that's exhausting. Right. And that's probably not, necessarily if you're there to help them with physical therapies and such, your primary thing. But we did discover that we couldn't compensate very well by phone, and we don't know why that is. But I have to say it's consistent with other research we've done, that in-person is just it's superior. I think all of us know that we would rather be in person right now than on Zoom. There's something about it. Right. Phone is the same way. Yeah. So yeah, I think it exacerbated a lot, and it's an issue that we have to think about going forward on both levels, is how do we get the social needs people have and how do we support the caregivers? Right.
Great point. Heather, do you want to comment at all? I don't know if you've seen something similar in North Dakota.
Yeah, so a different study that I've been working on, which is really evaluating, we have a service agency that is trying to provide services to older adults in rural areas, right, to support their aging in place. And during COVID, they really tried to switch everything to virtual and less of that in-person contact to try to protect, both their volunteers and their staff, as well as the older adults. And we just recently have been looking at some of the survey data that we did on how people were adapting to that, how the older adults were adapting. And even the ones that were adapting really well to the technology, right, that said, I like this Zoom, it's great, it's very helpful. They also said, but I don't want that to be the only thing, right? Like, I can have that as an add-on. Like, that's a great add-on once a week or once a month or every so often, but I need the in-person. And just kind of more anecdotally, just begging their service providers, when can you come back? When can you come in person? Because this just isn't working for me to try to communicate via phone. It's not the same for social support.
And I think the other thing is, it's not just the care provider that's experiencing this stress. I know that the state of Iowa just had it was either a law or an executive order or something that the families demanded that everyone, it's like right to visit. So long-term care, everyone gets to have one visitor or something like that, so that the families felt like we don't just want the care provider to have this contact where there is family. I mean, some people are really alone, but I do think that's an interesting component as we've been thinking about the burnout for caregivers, is that families in the US are accustomed to being more involved.
Right.
Yeah, and that was a big thing that we saw in both of these different studies, was caregivers really struggling with not having access to their loved ones. So, I can recall one wife that we interviewed that her husband was in a nursing home, and she went months without being able to see him, right? Just because the nursing home was locked down, nobody could get in besides staff. And that was just very distressing to her. Throughout the entire year, as we talked to her, we talked to other people that they had their parents that they couldn't get access to, that they couldn't see in person. And, even if you're not providing those daily cares because they're in a long-term care facility, you're still a caregiver, they're still your loved one. You need to be able to see them in person. And so I know we really had to make some tough decisions there, and different states made different decisions, different long-term care facilities did. But there are going to be long-term repercussions for a lot of what we saw in long-term care.
Right. So I'm hearing a couple of things. One is older adults coped well. They had the advantage of lifespan development, positivity, and yet there was loneliness and isolation. Heather, your studies of loneliness may shed some light on this. Who was lonely and how bad was it? Or who is lonely? I suppose we're still not completely back to normal.
I think to preface this, there's quite a bit of variability among older adults in their loneliness. And, I think there's obviously contextual and demographic factors that matter for loneliness, a lot of personality differences in loneliness as well. I think that in general, what we're probably seeing is that those that were lonely before COVID, COVID made that worse. I'm not sure that we saw this huge uptick in loneliness because of COVID, like we expected, or that some expected, right? So in our study, we definitely saw some people with increased loneliness, not a lot though. So the increased loneliness that we saw in those early days of COVID, was less than a quarter of our sample, a relatively small sample. But what they said is that they felt that they really lacked control, and that really bothered them, that they couldn't control where they went, what they did. They just really were struggling with that. And so it was this lack of control. And often they were people that were relatively busy, right? That they were going to the senior center, they were going to the cafe, they were seeing a lot of people, they were going to church every week. And so losing that and having it not be their own decision was really striking to people. And so that, I think, goes with also just a feeling of loss, where they saw the pandemic as really a feeling of loss. So there were definitely that group there that really struggled. But we also saw a group that really seemed to be resilient, and that we were giving them the UCLA loneliness scale, and they were just, low across the board, like, no loneliness, no nothing. And sometimes we would see a little bit of cognitive dissonance there. So I think there might be something to say with the specific region that we were conducting this study in, because the upper Midwest is kind of a very hardy, you don't complain about things. And so that's one of the areas where I saw some limitations to the measure, where we would ask, about loneliness or feeling left out. And they would say, well, based on the situation, based on what's going on, no, I'm fine. And maybe they just told us a story about how their whole family got together and they felt like they weren't a part of it and they were really sad about it. And then we'd ask them if they felt left out, and they'd say no. And so a little bit of cognitive dissonance there, that I really felt like maybe there was a bit more loneliness, but people weren't necessarily seeing that, right? Or perceiving that. One of the words that we heard a lot from people was lonesome. And so they would say, I'm not lonely, but I'm lonesome. And I really had to think a lot about what is the difference between those two words, because I'm hearing it over and over again. And I think it really is that the loneliness to them felt like permanent, like this is long term, that if I'm lonely, that means there's actually something wrong, and this is going to stay this way, and I'm not going to bounce back from it. Whereas when they'd say lonesome, they really thought about it as being temporary, right? And so the refrain we constantly heard was, this too shall pass, this too shall pass. When we looked at the people that really didn't report any increase in loneliness, and we're just kind of maintaining stable levels, not feeling lonely, there were a couple different reasons or kind of descriptors that I would give for those people. One group of them was really just accustomed to being alone, right? They lived alone. They didn't have a lot of visitors. This was what their life was, and they didn't really see a big difference in it, and so they were accustomed to it. So we would have people say, well, my husband's passed for 12 years now, I'm used to being alone, this doesn't really change what my life looks like. And so we definitely saw that more in kind of the older and more frail group as well, the ones that weren't necessarily still driving, weren't getting out. We also saw those that really seemed to have the strongest coping skills as having the lower levels of loneliness as well. So coping through connecting to others, having hobbies, staying busy, a lot of different ways that they coped. with potential loneliness to the extent that they didn't feel lonely. So I would say in what we saw, the majority did not report loneliness, and we're not really reporting that they felt this increase in loneliness, which was really interesting because we did expect much more of an increase, much more of a bump than we saw.
Were you able to look at any socioeconomic differences or health differences in reports of loneliness?
We've tried to look at some of those different aspects. And again, it's a small, more qualitative study. So it was a mixed method study where we did ask, a few of those scales like the loneliness scale, but more open-ended questions. One factor that really was interesting is that we saw a difference in loneliness between the rural participants and the non-rural participants. And so the ones living in those rural small towns had lower loneliness than those in the metropolitan areas. And the metropolitan areas are small cities, right? We're not talking about millions of people, we're talking about like 200,000 people. And so they really, I think, just were more used to social activities. They were more used to going out in public and more used to going to the senior center and the church. And so those individuals that were in those more metropolitan areas, I believe they have a lifestyle that was more active. Those individuals in the rural areas were, I don't want to say more isolated, but they just kind of lived a little bit of a slower life, less going out, less activity. I think that's one piece, that their lifestyle was different. The other piece that I think we heard a little bit as to why rural individuals may have experienced less loneliness is it did seem that they also were following precautions a bit less. And so I think there's a bit of perhaps a political divide or just a difference between those geographic regions where because we're living in such a small town and a small community, we haven't heard anybody have COVID yet. It's not here yet. So not taking the precautions, which I think was really interesting. And we saw that continue throughout the whole year of just, well, it's a small town. And, sometimes I would interview someone and they tell me about their neighbor that had COVID. So now they were taking it seriously. But before that, really feeling like, it's not here. It's not in this rural area. It's in the big city. And the big city is Fargo. So.
Karen, did you see anything about loneliness in your studies and maybe your experiential sampling?
So I think that one of the interesting things that Heather raised that I think became increasingly important in understanding the meaning of place to people. So there were a few things that went on. And I think one of the difficulties we have as gerontologists is the heterogeneity of the population. So there's no doubt, I think, that people who were isolated in the long-term care facilities, whether we could assess that they felt lonely, we can certainly see the consequences of memory loss at a much faster rate, of physical deterioration. So if you think of loneliness as sort of a consequential event, why do we care about loneliness? That's why we care about loneliness. They are showing much more the markers of it. When you look at some of the national samples that Heather and I talked about earlier, you get positivity, you get life experience, you get this, I'm used to this because of retirement. And then, so they've somehow got things set up. It also depends if you live with someone. If you live with someone, we never quite looked at the opposite, like, oh my God, were you desperate for solitude? I mean, I remember because I love my kids and I love my husband and we just all get along great. But for Mother's Day that year, I was like, could everybody just go out for an hour? And we didn't look at that aspect of it because we're so concerned with loneliness. And I suspect that the opposite was also true in some situations, but perhaps it's still more beneficial to have those people there than not. We are inherently social creatures. So yeah, we're seeing some good coping in some parts of the population. I still wonder what we didn't capture, I guess I'd say. And then, young adults, I think, had a much, much higher rate of loneliness. And it's perhaps the stage of life where you're supposed to be bonding and mating and everything else.
Right. Yeah, I think one of the unstudied aspects of coping in the pandemic was the size of your house. Big houses with lots of rooms may have been an advantage when you have to spend a lot of time at home, So I've always been curious about that.
Another one that I would put in there is weather, climate.
Yes.
One of the big things that happened to us in our study is, so North Dakota, one of the coldest places in the country. When it gets cold by November, we're starting to get cold already. You can't do things outside. And so we just saw this big shift as people started to during the summer do things outside, get together, we can stay socially distant, we can, be outside, it's safe. I don't know how many people we interviewed that talked about having their porch set up with chairs that they'd measured to be 6 feet apart, and they're outside, and that's how they can get together with their friends and have coffee. And then the fall hit and they couldn't do that anymore because it's too cold. And so they're shut in for 6 months, which is often kind of happens during non-COVID as well, especially for people that don't feel safe driving. But just thinking about the differences there. So would we see something different in Florida, where in the winter you can be outside, but then you have the opposite, some of the climates that are really hot in the summer, so you're not going to be outside then. But just an interesting thing to think about is, could you take advantage of socializing outside?
So you also mentioned one other aspect of your research. You're looking at how older adults figured out social engagement during the pandemic. Did you discover interesting strategies or approaches to the question?
Yeah, I mean, so the one that I just mentioned was there were some interesting strategies we called kind of creative strategies, where people would figure out a way to meet outside, figure out a way to connect through windows. Some people that would like go on a walk together, but both of you are on the phone, or walk on opposite sides of the road, which that feels a little bit too social distance to me, because I don't know how, like, are you yelling across the street? But figuring out ways to get together creatively, I definitely think we saw more of that. We just saw some interesting shifts where people felt like their family connections were growing closer. But particularly for those people they were already relying on. So one of the things we saw in the first interview was everyone was telling us how all of their family and their distant cousins and their nieces and nephews and grandchildren, people that normally didn't call them, were connecting with them. So those first months, weeks and months of the pandemic, there was just like an overload of social connection. And then by 3 months in, that had stopped. And so a lot of people had said, no, nobody's really reaching out to me anymore. It's just, my daughter or my granddaughter, the 1 or 2 people that they relied on, who really were their caregivers, right? Their primary source of support. And so we did hear people say they felt like those connections got stronger. And as Karen mentioned earlier, a lot of gratitude. And so just a lot of, I'm so grateful that I have these people, right? I have my daughter, I have these people who are looking after me and bringing me my groceries or mailing me things and making sure I have all my needs met. Interestingly, we do have to think about that there are people out there that don't have those resources as well, though. So while the majority of the people we talked to did have that, if we think about that, 10% or 15% or whatever percent it is that they don't have that primary care person, those are the people that I think we really need to be concerned about. And I'm not sure we have great ways of identifying them. Some of them are in our research, but I think they're more difficult to research and more difficult to get into programs and get access to. I would say another big thing that we saw was really the importance of friendship. And this just really, to me, validated a lot of the research that we've seen in, recent years on why friendships are so important for older adults, right? That I think it's really a stereotype in thinking that family is the most important for older adults. But we know from the research that friendships and those peer relationships are really, really critical for their well-being. And so we saw that people tended to still be seeing their family in person, but not their friends in person. So they kind of drew this line, and often it was a line drawn by their families. So we talked to multiple people that said, my daughter won't let me see my friends, which is just, that's another really interesting dynamic that we could get into, but that they weren't able to see their friends because the senior center was closed down and church was closed down and all of the places that they would socialize are not open. And so really just missing those friendships. And we would ask, well, are you talking to them on the phone? Yeah, we talk for, 5 or 10 minutes. We check in on each other, but we don't have much to talk about because we're not doing anything, right? When we meet in person, we're going to talk about what's going on and what's happening with our grandchildren and what we see happening around us. And we're not seeing any of that. So we'll talk for 5 minutes and there's nothing to talk about. And so while we see some of that creativity, I think the friendships was also felt as a big loss for many people. a loss of being able to connect to their friends. And I feel like, Karen, I just read a paper of yours that spoke to that as well, or something.
Yeah, we have a couple. One of my doctoral students has been looking at friendships, and I have to say the majority of phone calls in our study were between friends, as you acknowledge, and it left them feeling more lonely, perhaps because of what you just said. There wasn't any content to discuss.
Yeah.
I have to say one of my sort of disappointments during the pandemic, and particularly living in a city like Austin, was sort of the lack of creative solutions. And I think it was just the overwhelming need. Like I read about in another study, a mother, just, I don't know what, they were talking about creative solutions. And they were saying this mother was driving and her son suddenly saw a parking garage and said, "Look, mommy, there's a church." Because their church was meeting, they were driving to a parking garage far apart and using a megaphone so that they could see other people.
Mhm.
And I think that I don't know if those things would be effective or not, but I do feel like a lot of it was crisis mode for us as a field. What can we do? How can we keep people safe in a nursing home? What can we do to get those vaccines out? And now I do feel like we've got to be realistic that there's going to be a next crisis. And now is the time to think through those creative solutions that I don't think we're there. And I think, as Stephen asked earlier about the burnout for the caregivers, because we didn't have, for formal paid caregivers, we didn't have anything in place yet. And it just became their burden to try to solve all this need. And I think as a field, we've got to begin to think about that more going forward.
Yeah. And to that point, I think, what are we identifying as those top priorities? What are the critical care? Because you mentioned caregivers. And one of the things that we really saw was caregivers in one of our studies that were lacking respite care, right?
Yeah.
And so the respite care services were shut down because of COVID precautions. And that wasn't deemed essential care, right? But for those caregivers, my goodness, was that essential care that was missing, and that they were desperate for that break, especially if they were, had a loved one with dementia and some of those memory issues that, you couldn't leave them alone for much time at all. And so I could completely agree with that. We need to figure out creative strategies and also really think about what is critical care, what is essential. And I would advocate, and I'm sure Karen would as well, that social connection is critical. It may not be that basic need like groceries and, food and water and all of those things, but we know it's really important for well-being and health and longevity. So I hope that in the future, we really think about how to prioritize it in situations like these.
Okay,
Yeah.
thank you. Both of you were in our last couple of minutes, and a really good question is, will everything snap back to the way it was before if we ever turn this pandemic into an ordinary endemic disease? Or will we be able to learn from this and identify vulnerabilities that maybe we need to address before the next big one, if we can? And I just leave that as a parting thought, but maybe someone from the audience would like to raise a question to our terrific speakers in our last minute or two. And if you're so bold, put something in the chat, or perhaps raise your hand. And maybe Judy can help me identify people if someone does want to ask a question. Do we have any takers? I just see introductions and lots of talent out there from all over the country. A question? All right, well, I don't see any. Oh, wait, maybe? No? Okay. All right, well, I would like to just thank everybody for a terrific discussion. So many important points have come up here. And really a whole research program for the future. And I think something, just as a thought that's probably not original, but these kind of stresses on our society really teach us so much about aging and the populations we work with, and the delivery of services and many of the other factors, and also the resilience and coping and creativity of older people and their families and their networks. So much that we can learn from these kinds of episodes. And I hope also that we can continue thinking about these. And let me just put in a personal plug as the editor for the newest GSA journal, Innovation and Aging. If you would like to work on any of these topics and would like to prepare a paper in this area, please let me know. We're thinking now about a special issue to think about how research has had to change in the COVID era, or what we can predict the future will be post-pandemic. And if anybody would like to think about this and propose paper topics, I'm of course very interested. So with that, it is 1 o'clock. Let me thank you all again for attending, and especially my two speakers who were terrific. I knew they would be. And thanks again to the GSA and Judy Liu for organizing a terrific session today. So thank you again and goodbye. And I hope to see you all in November, maybe virtually, unfortunately not in person, for the GSA conference. Take care now. Bye.